That's the audience.
Okay.
That's the audience there. You can for the audience, you just go through here, guys.
Okay.
Alright,
All right, start all over again.
Yeah. Action.
Hello, I'm Dr. Halim. I'm here today at the annual Empire Aesthetics meeting with our panel of expert board-certified physicians and with Dr. Stephen Cosentino, who is the president, founder, and medical director of Empire Medical Training. I would like to introduce Dr. Cosentino and allow him to speak about Empire Medical Training and why we're here today for their big event in New York City.
Thank you, Dr. Halim. So, hi, I'm Dr. Cosentino. I'm very excited to be here. And before I talk a little bit about some of the new things that we're doing for 2019, I'd like to just kind of share with you a little bit about why I think I have the best career, best job. And I mean, for one, we're an educator. I'm an educator, and we're working with physicians in aesthetics, and that in itself is a very exciting field. And the main thing that I do as the president of the company is, you know, for one, I have to constantly look for new technologies, all the newest stuff, and it's like there's always things coming out in aesthetics that's new. So that's kind of the fun part. Next, we have to decide if it's something that we're going to train all of our practitioners, if it's going to be a workshop, a general seminar where we have nurses and physicians and lots of different people, or if it's going to be more of an advanced level training where we have prerequisite training and only allow, let's say, certain specialists, or if it's even going to be a preceptorship, because we have a lot of different types of training programs with the company. The next thing also I'd like to emphasize, of course, we're here with our dream team in aesthetics, and this is anything from hair to feet regarding treating patients and so forth. So it's very exciting to be with these physicians, but really what's important about all the physicians that we work with, and the reason why we're very proud of this, is because they're very strict in the way that they teach. And that's very important, and it's something that we stress with our training, is that the training itself, you know, what's more important than just providing this education is making sure that we're teaching our providers in a way that's very safe. They're going to learn techniques that they're going to turn around and work on their patients in a very safe manner, because again, this is aesthetics, and we want to make sure that nobody is going to be hurt in any way. Just a couple new things that we're doing for 2019. We have, there's so many new things. We have, for one, we've been working on this year is our new training center that we have in New York, and it's a state-of-the-art training facility. We have lots of new equipment that we're going to be using for training, and it's been very exciting. So that's going to be opening up first quarter of 2019. We have lots of different training programs. If you look at aesthetics, we have level 1 training, and we've had that for a while, level 2, but some of the new programs that we have for 2019 are going to be more advanced topics. We have a new master level training series, which is very exciting. We also have an anatomical based aesthetic training program, and that's actually something new. We've been doing this for our pain management training for over 20 years, and we use cadavers, and these are injection programs. So we're going to have new programs for next year using cadavers. And this is important too, because as we were talking about earlier, you know, with some of our students, we want to make sure that everybody's understanding the anatomy correctly, and it's all part of teaching and implementing safe protocols. So that's a big program that we're going to be having starting in 2019. Some other new topics, just off the top of my head, we have a lot of training with threads, and some of the new things that we're doing now with threads are combination therapies with fillers and with lasers and different things. So that's very exciting. We're working with different companies as well. A lot of trainers are sponsored by one company, and we're not doing that, you know, because we feel that really all the threads are good, and we want to make sure that our members have a choice and they can decide for themselves. And there's so many good applications that you can do with all the different threads. So that's something new. Our master level series, our advanced training, our state-of-the-art facility. There's so many new things, so we're excited. And I'd like to thank our staff, our panel, for being here today, and back to Dr. Azza.
Thank you. And as Dr. Constantino emphasized with the aesthetic meeting that we're having here and our board of experts and panels, let me start by introducing every one of our members here on the panel and with their credentials. And I will start off by giving a little bit of background about Dr. Constantino. Besides what he just had said, is he's been training physicians for the last 20 years. and he also is having anti-aging, weight management, surgery, and pain management courses, as well as the state-of-the-art facilities. He's also constantly recruiting and seeking out the best as far as instructors for the program, so that way any new students may get the best possible training out there. I would also like to then introduce Dr. Gregory Buford. And Dr. Buford is a board-certified plastic surgeon who specializes in minimally invasive facial rejuvenation, breast augmentation, breast contouring, body contouring. He's a nationally recognized board-certified plastic surgeon who received his medical degree from Georgetown University School of Medicine. He did his plastic surgery residency at the Cleveland Clinic. He also has so many accolades, and just to name a few, he's one of 12 of the Allergan certified master facial injectable trainers in the United States. He has authored the book called Beauty and the Biz, and most recently authored Eat, Drink, and Heal, and he is a well-published author. And this would be Dr. Greg Buford.
Thank you.
Next, I would like to introduce Dr. Shino Bay Aguilera. He is a board-certified...
Hold on a second. Don't worry about looking at the camera when you're reading. Okay, yeah, very funny that about that. It's fine.
Yeah,
Don't
that's
worry
okay.
about looking
Just
at
I
the
want to
camera.
make it easier. Don't worry about looking at the camera because back and forth. Just read it. I will get that in the screen. I will get that in the screen when you're saying it. Just read it. Don't worry about back and forth in the camera when you're giving your credential.
So you don't want me looking at them, or you do?
No, when you're doing the credential, you read it. You're going back and forth, back and forth.
Oh, because I'm trying to look at you.
Yeah, just
Okay.
don't worry about it. Just read it.
So you want me to redo Dr. Buford's credentials?
No, just
Go start with Dr. Shino.
That's Shino, that's
Okay.
so.
Dr. Shino Bay Aguilera is a board-certified dermatologist and surgeon. Dr. Aguilera is world-renowned. He's multi-award winning cosmetic dermatologist, dermatologic surgeon, cosmetic laser expert, and is dual board-certified. Dr. Aguilera is a top-requested physician trainer for Sculptra. He is the #1 injector for Sculptra Facial in the United States and in the world since 2009. Dr. Aguilera's Cosmetic Center has been officially certified as one of the world's most prestigious laser center of excellence in the entire U.S. and Latin America. Next, we have Dr. Tisei. He's a board-certified emergency room physician. He received full academic dean scholarship from Emory University, where he received his Bachelor of Science and Master of Science in Quantum Chemistry within 4 years and graduated as summa cum laude. Dr. Tisei has completed his residency training in Compton, South Central Los Angeles, treating the most critical medical patients, including some of the worst trauma cases in the country. He is a board-certified emergency medicine physician practicing more than 17 years and is now devoting his career to full-time aesthetics. He is a huge success story for Empire Medical Training, as he began his training with Empire in 2015, which is just one of how many ways that Empire does train, and actually we have graduates from Empire Medical Training as success stories. Dr. Tisei now operates one of the busiest and most successful aesthetics practice in the nation. He has become a sought-after speaker and is a top injector for Allergan. He was invited in 2017 to speak at Empire's 20th anniversary celebration, and is here again this year to participate in the aesthetics meeting. He's the founder and medical director of Ageless MD in California. Next, we have Dr. Alan Bauman. Dr. Bauman is a full-time hair transplant surgeon who has treated nearly 20,000 patients and performed over 8,000 hair transplant surgeries to date. Dr. Bauman has received his medical degree from New York Medical College, completed his surgical residency training at Mount Sinai Medical Center and Beth Israel Medical Center in Manhattan. He completed his hair transplant fellowship training in New York City. Dr. Bauman is one of only 200 physicians worldwide to achieve certification from the esteemed American and International Board of Hair Restoration Surgery. He is also an accepted member of the International Alliance of Hair Restoration Surgeons and also recommended by the Hair Loss Association. This past year, Dr. Bauman was named a top 5 transformational CEO and one of 10 CEO transforming healthcare in America in Forbes, as well as voted as North America's #1 top hair restoration surgeon for the 2nd year in a row by Aesthetic Everything. Dr. Ramtin Kassir is our next panelist and triple board certified plastic surgeon. Dr. Kassir has been in private practice since 1997. and has extensive experience in the fields of facial plastic surgery and cosmetic surgery, endoscopic surgery, laser surgery. Dr. Castillo has been featured on The Real Housewives of New Jersey, Fox News, and ABC's The Doctors. And lastly, regarding myself, I am Dr. Agha Halim. I'm a board-certified anesthesiologist, critical care medicine, trauma, as well as pediatric anesthesia, who specializes in aesthetics, integrative medicine, anti-aging, and facial rejuvenation with non-invasive procedures. I practice in Boca Raton, Florida at Sanctuary Medical Center. I also speak for multiple companies as far as lasers, PDO threads, combination therapies, as well as for Empire Medical Training.
Excellent.
Cut.
Let's get this, that was good. Okay, let's continue. I know. So let's
It's
take.
fine, we recording live, it's fine.
Oh, okay, I thought you were doing it in bits.
Let's go next,
Bits.
let's go
Okay.
next step, yeah.
All right, now I can put this away. So next, what we're going to do today is actually with a board of panelists, as we said, experts. We're going to be reviewing several case studies as far as procedures and treatments. So we're going to look, evaluate, assess, and then come up with a treatment protocol plan by all the pearls of the experts that we have here today. And you will see here we have Dr. Stephen Constantino, Dr. Shino Bay. These are some of the models and pictures, and what I would like to do is have our panelists here, Dr. Shino will talk about his patient here, and we will ask questions as to how everyone's approach may differ, because you may have several different approaches in the world of aesthetics. Not everything is going to be identical, it's just not cookie cutter. It's a matter of expertise, skills, and clinical experience, which is what makes one person more cutting edge than the other. And this is what we try to share with all the students at Empire Medical Training in order to be able to enhance their skills, teach them about safety, anatomy, and what the best way it is to be able to deliver to your patient in the consultation process as well as results. So Dr. Shinobe.
Okay, so this is a patient of mine, 45-year-old female, and I'm very interested to see some of the members of the panel to tell me how you approached it before photo, and then I will tell them what exactly I did to achieve this look on her. Great.
First thing I would do is it was medical skincare. I think her skin is rather heterogeneous. I'd like to actually create more uniformity. I get her on a medical skincare regimen. I would do chemical peels, and then after that, I would actually look at incorporating the toxins, basically in the upper third of the face, around the eyes, and then I would look as well too at replacing lost volume in the mid face, and also too around her mouth, most specifically in the marionette lines. But I think the big area for me would be probably the mid face, because that really to me anchors the look of the whole face and gives it proportion, symmetry, and balance.
Perfect at the time.
Me?
Yeah.
So it's really interesting. And kind of knowing your background, I suspect that maybe some sculptures may be involved, because you mentioned the skin care, because the skin obviously looks better, but probably some resurfacing, maybe a photofacial. Going back to the volume replacement, it's interesting. I don't know if it's the lighting, but her forehead looks improved. So I suspect maybe some forehead fillers, which I know you're really big into. Toxins, of course, around the eyes. Medial cheek, I think, is important here, because it's going to elevate her nasolabial fold and improve the overall lower third of the face. But nice job. Very subtle improvement, but very impactful.
Dr. Castillo?
So I'd have to agree with most of what the other panelists have said, but it looks like her face is a little bit more rested and a little bit lifted. So I would suspect that you may have used some sort of neuromodulator for the upper third and even the lower third periorally. And looks like her lips have been kind of redefined a little bit. The corners of the mouth have been lifted. So maybe perhaps some fillers around there. And I think the rest of the face, I'll guess that you've kind of volumized it with Sculptra, because if I'm seeing correctly, her temples look rejuvenated too. So I think the overall kind of, it's more of a high V oval shaped face. So it's been lifted. Now whether with the sculptor or not, it looks good and her skin looks better.
Perfect. Yeah. So I'm gonna tell you exactly what I did, and I agree with all of that. We definitely put her in a skin regimen program with one of our estheticians. I think she was using like Clear Brilliant, Hydro Brilliance to improve the quality of the skin. My part was I actually ended up using Radius, and I did my HD Sculpt technique, which is using a high G prime product in order to recontour the face. As you could see on the before photo, she looks a little bit heavy on the cheeks. Things are coming down due to volume loss on the mid-face. But as you can see that she has kind of like a square face. And we're trying to get this oval shape. So I did Radius, I did work on her temples, mid-face, the jawline, and I did treat the masseters with neurotoxins because she is a clencher, heavy clencher and grinder. So that's why the whole shape of the face changed. And then she had neurotoxins on the upper face, and I did mesotox, which is injecting very superficial on the skin to alleviate the tiny wrinkles around the eyes. So that was my technique with this patient.
I have a question for you, Dr. Shino. So when training, actually, it's interesting because I think sometimes it's actually easier to train somebody who's never even worked on a patient than somebody who's had more experience. Can you maybe talk a little bit about some common mistakes? Because I could see some right off the bat. When you look at a patient that has deep nasolabial folds, I know what a common mistake is for somebody who hasn't done much. They want to go in and inject the nasolabial fold right from the beginning, right? So maybe you could talk about some common mistakes that people should avoid.
Definitely,
as part of the training.
Definitely, I think that's very important. I think one of the way that I teach my residents or whoever I'm trying to train is that in order to pick the right product for the right patient is understanding the personality of each fillers and what you're trying to achieve. A common mistake is trying to alleviate the nasolabial fold. The nasolabial fold is a symptom, but in some cases, her symptom, if you look at the before photo, is that she's losing a little bit of the volume of the mid-face, but because her clenching and grinding, the maxilla is moving retrograde. So instead of injecting in the nasolabial fold intradermal, I actually use Radius, supraperiosteal, and the canine fossa and piriform, close to the piriform aperture to trying to bring that volume and alleviate the nasolabial fold by elevating the face by using a higher G prime like Radius on the cheeks. And then I went supraperiosteal and the canine fossa. I never injected the skin per se. Sure. You never want to use a high G prime product in the nasolabial fold because it will affect the smile.
Sure, thank you.
Yes,
Okay,
we did
great.
a photo. So, a tough case. Let me see. TJ, what?
Yeah, this is a tough case. She's got just some overall laxity, skin quality, some photo damage, and starting from top down, I can see for sure. You want to start with your toxins, kind of lift her brows now appear lifted. That could either be done with some toxins or even some fillers, periosteal above the brows to lift those brows. For sure, we targeted the medial cheek and a little bit of tear trumpet, not too much or even overcorrecting, and also giving a very subtle volume enhancement, which actually helped her nasolabial folds as well. And of course, maybe some laser resurfacing on top of all of that.
Dr. Kasir?
So it looks like, her skin looks shinier, so whether you did anything to the skin per se, whether laser or skincare regimen looks better. The upper third of the face, the forehead, frown lines, and crow's feet around the mouth has settled and been repositioned, so I'm going to say you used neuromodulator there, and you've definitely used some sort of volume. I would suspect an HA under the eyes, and again periorally, and her jawline looks contoured.
Perfect. Greg?
I mean, I don't know what else to add to it. I mean, what I would say is everything that Dr. Kassir said, but in addition as well too, that there was a lot more focus on the mid-face and also focus too on the perioral lines, basically restoring volume. And again, echoing what he mentioned as well too, that there's an improvement in the skin tone, because the skin tone starting out, I mean, is pretty suboptimal. She has fine lines and rhytids. She doesn't really have a nice shine. I mean, now she has a nice glow. It looks dramatically improved. So basically, rejuvenation from the outside in.
So great mind thinks alike, and that's basically exactly what we did. Skin quality was first. What we did a heavy duty CO2 laser. We were a few weeks, usually I wait 2 to 4 weeks. I can't remember, but usually 2 to 4 weeks, and she did sculpture aesthetics. And then definitely after that, she got neurotoxins and fillers on the bed. So it was a combination therapy in order to get these results.
And combination therapy is something that we are trying to also focus on. And something else that I actually would also add to this patient here is eventually to be able to do some mesotherapy or kybella for the chin underneath the submental area. And then at that point, probably do some jawline contouring with whether it's the sculpture or the radius. I tend to use a lot of radius for jawline contouring. That way it'll give her more definition, more angled, chiseled look, which a lot of people are looking to get, as well as that way too it'll enhance her cheekbones and give her more of that sculpted look as well.
Perfect.
I also noticed that she has little weak eyebrows and eyelashes, so I might think of some serums and such for the eyelash enhancement, or if she's weak in density out in the lateral brow, maybe some transplantation to fill in or thicken those areas.
It's great because we know that the biggest change that you could do on a face is the shape of the brow.
Yeah.
So that's great.
Very true.
And we're so glad and happy that we have somebody that's an expert in this field that can see brows and hairlines.
See brows all the time.
Let's see.
I have a question, Shino. Did you do anything perioral? Her philtrum looks shortened and elevated.
So yeah, that very good observation. That is due to Sculptra injecting in this piriform aperture. I tend to shorten that with that, and also tend to lift the tip of the nose as well.
Beautiful.
Next case. Well, this was a very tough case, and so I'm very curious about what anybody has to say on this panel.
So if I may first say, the first thing if a patient walks in like this, the first go-to would be literally a facelift, an upper and lower bluff, and a neck lift. That's from a surgical standpoint. If you were to approach it from a non-surgical, minimally invasive standpoint, you actually then would approach the combination therapy with the neuromodulators, fillers, skincare, mycotoxin, and laser resurfacing as well as radiofrequency microneedling for skin tightening.
Okay.
First thing I would talk to her about is realistic expectations. A patient like this comes in and said, I want 30 units of Botox, and that's all I want to do. And I want to look like I am on the right. There's no way in God's green earth that you're going to be able to accomplish that. Okay, so setting that realistic expectations, first and foremost, is really, really important. From there, I just say, this is an ongoing process. You're not just going to have one procedure; you're going to have multiple. So I'm sure that's what you did. Aggressive. She needs to be on a good medical skincare program. Aggressive resurfacing. Volumization of the mid face, of the lower face with support. You obviously added some volume to her lips as well too. You used a neuromodulator. All these things, as you pointed out, combination therapy is really what all of us are doing nowadays. And with this, you really create synergy and you get this kind of result. Because honestly, if she came into my office, I would probably refer to someone like Dr. Kassir for a facelift. Because she's not someone that's depending upon her expectations, she may not be able to accomplish what she wants to accomplish with non-invasive or non-surgical means.
That's very true.
Dr. Kassir?
I have a couple of comments. First of all, what an incredible non-surgical result.
Thank you.
And I commend you on that. So this looks like the other panelists have said, but this is combination therapy. She's definitely had neuromodulators. She's had a multitude, I would expect a multitude of fillers in different areas. The skin has, I would guess, at least been resurfaced. And what's really dramatic to me, if you look at her eyebrows, she has hooding of the eyebrows that are asymmetric, and you've managed to not only make that much more symmetric, but you repositioned her eyebrows, pretty much repositioned her face. So again, commendations. The one thing that I would, because Dr. Constantino wanted to talk about mistakes, draw attention to is the distance from her base of her nose to the top of her lip is really, really long. I would say it's north of 2.3, 2.4 centimeters. So to add a lot of filler to a lip like that would just make it look a lot worse, and that's when you get the proverbial duck lips, where you're adding filler to a long lip and elongating it even more. So be careful about that.
Any comment?
Yeah, so her hairline is a little bit receding in the temples, so we want to definitely try to protect those areas. We can use topical medications, laser light therapy, platelet-rich plasma to do that. If it's severe, obviously we can transplant those areas. The lateral third on the brow is also looking very, very weak, so maybe try with some serums in that area. If we're not getting the boost that we want, we can transplant some hairs into those zones.
Beautiful. TJ?
I was thinking, looking at the upper third, the forehead, I don't think you can get this kind of result with just toxin. So there must be some sort of filling in the forehead as well as the temples, and I think that also contributed to the eyebrow lift. Now, Dr. Kassir, like I do nanofat, and I realize you do nanofat as well. I would say, would you say that this would be a good case where nanofat all over, I think, could give similar results, and the stem cells from the nanofat can give that kind of skin rejuvenation that you see here?
Awesome. Well, I'll tell you what I did. So definitely aggressive treatment with a fractional CO2 at the highest setting. So it took a little while for her to recover. Then this is what I love Sculptra aesthetics, because I can get this type of result with my precise sculpt technique, supraperiosteal. Obviously she needed more than one session, so she ended up having 3 sessions. Each session is 8 weeks apart. I did do frontoplasty, and that's, if you could see to my right, I don't know if in camera is to the left, but you could see the frontal concavity is a little bit more severe on the side where the brow is more drooped. So we did use Voluma diluted with 0.8 cc of Lido, and trying to not only do the forehead but also include the brow bone, so under the brow. And of course, I did the best I could to attempt by doing a Sculptra in the preform aperture to try to shorten the distance between the tip of the nose and the lip. Improve a little bit, there's some projection, but you know, there's a lot of bone loss, but changes at our age. And then again, the neurotoxin to finish everything and try to bring harmony to this face. That really I agree with everybody on the panel. This should have been a surgical case, but some patients, sometimes they refuse to do surgery and they just want to look a little bit refreshed, a little bit better. But I think with Sculptra supraperiosteal, I can give them, to some of my patients, a little bit of almost like a non-surgical lift with injectable fillers.
The other thing that I just may add to as well, especially because since I do a lot of trainings for various companies with the PDO threads, so this patient actually would have also benefited from, and still can, is with the PDO threads to be able to do a brow lift, as well as if you place them in the forehead lines, they actually will stretch the skin, tighten it, build neocollagenesis. At that point too, it helps eradicate and get rid of those fine lines in the forehead, whether in conjunction with the neuromodulators or not. Also for the upper lip, the PDO threads, depending on which types you use, you're actually able to roll up and lift and pull up the lip as opposed to putting it in with filler. Because if you do overload the lip with filler on someone with that distance, as Dr. Kassir mentioned, you would actually roll the lip out and it would look like a sausage or duck lip, which people don't like.
Perfect. Beautiful. Well, I think those all of my patients, so thank you.
Well, nice job as well too. And what, I mean, just curious, what were her expectations? I mean, I'm really focusing on that, but I think that, you know, I think that's a very, very important aspect of what we do. Was she happy? Did you exceed her expectations, or was she even hoping for more?
Well, I think by the look of the pictures, she was thrilled, because she definitely is a patient that she says, I will never cut. And she wasn't expecting to look this good. She thought she was going to look a little refreshed, a little volume. And But over time, when she starts seeing the results, remember she did 3 sessions, so it takes a while to see the result with Sculptra. But even from the first session, there was an improvement in volume. People started noticing that she looked more rested, better. And it wasn't until we finished with all 3 sessions of Sculptra Aesthetic that she was actually able to see that she looked at least 10 years younger.
Yes, she definitely does. It definitely took 10 years off her face. Okay, and with Dr. Baumann, next we are going to go to the hair restoration patients.
Great. So this reveals exactly what I did, but I'll tell you, if you look at the frontal part of the hairline, this is a very, very common type of patient that we see in our practice. We treat many men who are receding in the hairline, losing frontal density up front from male pattern hair loss. So I'll tell you a little bit about his case. Martino is 43 years old, and he comes in with this significant hair loss, and he wants to protect what he has and restore the hairline to a more youthful location. And so what we did is we started on a regimen of medical therapy to stop the progression of the hair loss. So we use a combination of oral treatments, topical treatments, as well as PRP into that frontal area, all the way back into the mid-scalp and crown, which are at risk for hair loss. And then, of course, in the areas where the density is very low, we're going to do some degree of transplantation. And you see him in the healing process there. That's the middle photo. That's 1 day after the procedure. Those crusting and scabs are going to last for about a week. In the back of the scalp, we'll provide the photo. It's done minimally invasively, so this is without a scalpel, without stitches. We're doing the harvesting minimally invasively using an FUE approach, follicular unit extraction. And so what that means is that there's no scalpel or stitches anymore. We're taking the individual grafts one at a time, and we're implanting those in an artistic, angulated way in the hairline, so then when it regrows, it looks normal and natural and fills in the density.
Perfect.
There should be one more photo there, a few more photos of the end result. This is 12 months out from the procedure. You're seeing a more aesthetic framing of the face, increase in density in that frontal area, improvements in the, what we call the golden ratio, if you will, of the frame of the forehead. And of course, it's not always about what's going on the top of the scalp that matters. If you see his big bold smile, you know that he's doing well with the hair restoration that we've provided. And most people think it's pluggy or painful. Obviously, that's not the case today. With these kinds of minimally invasive techniques, you're not going to have any discomfort. He was back in the gym in 3 days, swimming and playing golf and tennis in a matter of days after that, and back to his regular routine really in a week. And then, of course, waiting for the hair to grow after that.
And this is the result at 12 months?
This is 12-month results.
And how many grafts was that?
So this was 1,850 grafts into the frontal hairline, temples, and mid-scalp area.
And how often would he need to maintain with PRP after that? And do you use also amnio or anything else along with
So
that?
that's a great question. So PRP is not created equally. Obviously, there's a lot of ways to prepare PRP and a lot of different scaffolds or extracellular matrix to add to the PRP. So we're using a high-density platelet count, somewhere between 1 to 1.5 million platelets per microliter, using a dual spin process, so we're not just getting high-density platelets, but also a high monocyte concentration is preserved, and we're using extracellular matrix with that. Personally, we've been using BioD, which is a placental tissue, a human allograft that's mixed with the PRP at the time of the injection. So he had his procedure and PRP on the same day, and that PRP result will last about 10 to 14 months. So he does need to come in annually, but he doesn't need to come in every other month or every month for a repeat PRP.
Great, wonderful. As well as the biologics and medications and supplements that you have them taking.
Absolutely. So, whether it be finasteride or minoxidil, those need to be continued open-ended. And he's a big fan of laser light therapy, non-chemical, non-invasive way to protect and enhance living and growing hair. He uses laser cap every day for 6 minutes, and happy camper.
Perfect, wonderful.
I have
Any
a
questions?
question.
Yeah.
So if someone like this, after the transplant case, then decides they want to go on testosterone replacement therapy, how would you advise the provider on that?
Yeah, so that's a great question. We see a lot of patients who come in either previously on testosterone or start testosterone after having noticed that they already have male pattern hair loss. and testosterone gets converted to DHT. So we know that's high risk. DHT is responsible for follicular homicide. So DHT creation in the body, if it's accelerated from additional testosterone or even just a high intensity workout regimen, you're going to start to lose more hair. So you've got to focus on that and fight the battle with some additional therapies and treatments. So we use finasteride to stop the DHT production. We can use the PRP, low-level laser therapy, compounded topical medications, and so forth.
So they can still continue the hormone replacement therapy?
Yeah, it's a tug of war, right? So we don't want them overjuiced on the testosterone. We want them on the least amount that gets them a good result that they want with their age management physician. And of course, we want to try to protect their hair at the same time. So it is possible to win the battle.
Okay.
Yeah.
And the new hairs are not affected.
Correct. So the newly transplanted hair is permanent, never affected by male pattern hair loss. It comes from the permanent zones or relatively permanent zones from the sides and the back of the scalp.
Nice.
But they still need to protect the native.
Correct. The transplanted hairs are permanent, but your other hair is not. So you still need to keep on keeping on
Yeah,
with
because
your
I
other
see that's where I
therapies.
see the mistake that a lot of people get a transplant and they think that they don't have to do anything or the PRP or supplements or anything, and then they find themselves that they need to do another one and
Sure.
another one. So it's important to get the message out. You have to protect the native.
And that's a recipe for disaster, because if you don't protect the hair that you have, then in the long run, you'd lose the battle. You know, and you're gonna need a lot more surgery to fix it. Not a great idea. So we have over 1,000 patients visit our clinic per year. Maybe 3/4 of them may never ever need a hair transplant
Wow.
because we're protecting their existing hair. And the transplanted patients are on a very, very strong regimen of medications and treatments and measurements to know how things are working.
Perfect.
Just want to say one quick comment. I mean, to Dr. Baumann, this is obvious, but to the people who don't do hair transplants, if you notice how the frontal hairline is not straight across, and it's what we call kind of like the V-fib hairline, and how it blends into those temples very naturally. That's the artistry that he was discussing, and I'd have to give that an A+.
Thank you.
Yeah, it was a very, I mean, great result, and very, as you pointed out, very natural looking as well, too.
Thanks.
Now, Dr. TJ Say, now we're gonna go to your patient here, and
Okay, so the left is obviously the before, and this is a early 40s Caucasian female. At this point, I've already done some fillers. I've already done a little bit of Voluma, a little bit of some Juvederm, a little bit of Sculptra, and she was kind of still looking tired and wanted to improve her overall appearance. Mainly was kind of like the sagging issue. So, Sheena, what kind of comments would you think that I possibly did on her?
So definitely, I think that trying to improve a little bit more the mid-face volume may help. Well, I don't know if that's what you did for the after picture, but it looks like her volume is much more natural. She looks a lot more useful, especially what you did around the perioral area. It looks much more improved, pre-gel sulcus, all stuff. So I'm thinking, and the quality of the skin looks a lot better. So I'm not sure if you did any light device or energy device to improve the quality of the skin or this defect of Sculptra. But overall, I think there was a great improvement on the mid-volume face. The shape of the face is more oval. To me, the best thing is what you did to the lower third of the face. I think it looks so much more useful and natural.
Thank you. Dr. Kassir, being a surgeon, would you comment on this, and if you would offer her even a surgical option?
I'll tell you, if that was a surgical result, I'd commend you on that too. So the fact that you did that non-surgically was pretty impressive. I agree with what Dr. Shino Bay said. The lower third, you've done an excellent job. The philtrum to me looks, instead of built in where that line is really a crevice, it's flattened out a little bit and it looks much more aesthetic. The mental crease looks better. The marionette lines look better. The jowls look better. And two areas that I see that look really, really good are the lower lid mid-face junction, especially on the right side, that's pulling away and almost looks like a festoon. I don't know how you corrected that, but it looks like volume, and you did a nice job. I see she has platysmal bands on the left and none after, so you've either done neuromodulator or used some serious energy device to smooth that out. So again, whatever you did, very nice job.
Okay. Doctor, could you comment on what you would, how you would approach this patient?
Well, I think she got phenomenal results. She definitely looks much, much more improved. As Dr. Kassir said, the Filtron looks much more natural, and her lips look better. The preaxial sulcus definitely has been volumized, and in that area, I would have used fillers. I basically tend to use either sculpture or radius in that area because it's just a much more robust filler for the jawline and chin augmentation. As far as the tear trough and under eye, and where you have that malar defect that some people do get, it looks like you may have used a particular filler underneath. The first thing though that I would have done, and maybe you have done, is before even volumizing contouring, is my go-to is usually doing some radiofrequency microneedling high energy device for skin tightening for pores, used along with combination of PRP for the quality of the skin. If the patient needs laser resurfacing, then at that point I go ahead and do that. As far as any kind of lifting and volumizing, I will do that with the fillers, and I also do adjunctive therapy with the PDO threads in conjunction with that to get similar results.
Excellent. Yeah, at the time I didn't have the RF microneedling, but that's a great comment, great option. So again, it is combination therapy, and I you know, in the before picture I already maxed out, and she didn't want to continue stuffing more fillers, and so I gave her the option of threads. So what I did was, it's a very simple solution. I used the Mint PDO threads, which are the barbed threads, 43 centimeters. I tacked it with a stitch into the temporal fascia and tunneled it down to the lower third of the face, 2 on per side, and did basically a thread lift on her, which I didn't even address specifically the neck. That wasn't even toxins. That was just the result of the lift. So just one therapy solution on the before and after on this one.
Yeah, great.
Just beautiful result. And one thing that I do PDO threads is being a learning curve for myself, and I use it in the place that you used it. I think that using threads, incorporating threads, is allowing us not to be so filler dependent. So I tell my patients that as the deeper tissue, especially the periosteum, is shrinking, you have 2 options. You either get fat, right, or put a lot of fillers. Would that be 3 options? Or you bring your dress to the seamstress. So you use the thread. I use the analogy that we're using the thread. It's like taking your dress to the seamstress to be tailored to your new anatomy, and that always allows to take a few syringes of fillers out of the equation. Because I think that if we continue with, especially HAs, and you put HA between the bone and the muscle, then you're injecting HA in the muscle, then you inject the HA intradermal, then you have this face full of HA that I'm sure that when plastic surgeons here trying to operate, that HA just pours out of the face like there's no tomorrow. So threads are actually is a game changer in the industry.
Oh, I agree.
Good job,
100%.
TJ.
Very nice results. And I think that is combination therapy, as Dr. Shinobe said, it minimizes the use of fillers. It does not negate the use of fillers, as I tell my patients, especially because in Boca Raton, Florida, everyone either wants to look 20 years younger and they want no downtime. So a lot of people that don't want to undergo the knife or have surgery or undergo anesthesia and recovery time. So the other option would be then to combine the PDO threads and minimize the amount of fillers, but still they need the skincare, the lasers, and they will need the neuromodulators. So it is definitely combination therapy. Anyone else have any comments to add to that? No?
Dr. Buford, would you offer her a surgical option?
I don't do facelifts, so I prefer over to Rompin. But what I would say though, I mean, when I look at her face, basically 2 things scream out at me. Number 1, improvement in skin quality. Number 2, volumization. So, you know, again, I would echo, this is a very good non-surgical result. I mean, I applaud you for this. You know, again, I'd get back to expectations because, you know, I have to imagine that for every 10 that you do like this, you're not always going to get a home run like this. Obviously, I mean, and there's no offense to you, but I mean, you know, I tell my patients the only thing that's predictable about tissue is the fact that it's unpredictable. You know, so we can you know get these home runs, but then you know we don't always accomplish that. So it's really telling them this is what we can do. But Doing what you did, though, I think this result looks great. So what I'd like to see is I'd like to see how durable it is in the next 2-3 years and so forth. How do you tell your patients? How do you set them up for that? I mean,
I tell them
they say
it's about
how
a year.
fast?
About a year.
Okay.
And the studies with the menthroids done in Korea they were all done at 12 months.
Right.
And they had like 80-something% satisfaction rate.
Right.
So I said
Which is still pretty high. I mean, that's
very high,
Yeah.
actually.
yeah,
Yeah.
yeah. I mean, nice result. It's very good.
Very nice.
Thank you.
This is another patient here.
So this lady, on the before, and you can, I have two before and after pictures, but yeah, you can compare, go back and forth between these two. So she was probably late 30s, looking for a new boyfriend and feeling really kind of tired. And
Did she find one?
She did.
Good.
A
That's a
much
success.
younger guy. So she felt like she really needed to keep up and look refreshed for him. So yeah, the before was before any type of treatment whatsoever, and then you can comment on the afterwards. We can start with you.
So in her before picture, she looks very tired. As you can see, the under eyes do look tired. She does have the tear trough depression there. She does also have the oral commissures. She has a deficiency in that area as far as the oral commissure. Her chin in the before picture is interesting because it looks fuller than in the after picture. So I'm not sure if there was any weight loss or if there was any kind of manipulation on your part as far as non-surgical. As far as the skin and quality, you can see her pore size has diminished. Her eyebrows as well have changed a little bit, but also the lighting is a little different as far as the shading and as far as the forehead. And this patient here, I would give her some facial definition and contouring because her cheeks are pretty flat. I would go ahead and give her some contouring in the cheek area. I would also give her some tear trough fillers. I would combine the neuromodulators. And it seems like you did some neck tightening underneath there because her before picture, her neck is also fuller. And underneath it looks at the after much better, much more improved. So mesotherapy, and when I say mesotherapy, and that's something that I try to clarify to people, meso is an actual technique. It's not about just Kybella. You can use meso, and it's something that started in Europe for 25 years, even way before it hit the United States. So meso is a matter of your technique, approach, and process, and what you're putting into the product. It does not necessarily have to be Kybella. It could be actually hyaluronics, it could be serums, it could be a combination of anything. When I say mesotherapy for the skin, that's what I'm referring to. I prefer to say, as far as submental fat dissolution, then you're looking at Kybella or PCDC, as far as shrinking the fat. And light-based energies, I think, are very important for anyone, and I always tell patients that they're never too young to start with light-based therapies. They're never too young to start with Botox as prevention for neuromodulation and lines and wrinkles, and skincare.
Would you go back to the other slide? I think that really kind of can show the work that was done. And Dr. Kassir, feel free next to comment on how you would approach this.
Yeah, I mean, I'd agree with what we just said. So absolutely treat her skin with skincare or perhaps even a laser. Fill what I call the shadows on the face, and it looks like some sort of energy or laser or maybe even a lift has been done on her with threads.
Chino.
So this is a Asian patient, and I know that Asian, they have great cheekbones, right? So the techniques with Asian have to be very delicate because the way you inject a zygoma on an Asian, the angle changes, have to be completely different the way you inject a Caucasian or Latinos or European patient. Asian is known that they have very flat forehead, flat nasal root, the maxilla is flat, and the chin tends to be retruded. So to me, you did a nice job achieving that oval shape, which is very desired in the Asian community. I think it is obvious that fillers used to give some of that volume in the mid-face, which most Asians lack. By doing that, you will improve the tear trough. I don't know, you injected the tear trough because sometimes just by improving the mid-face, the tear trough, somebody Asian descent will get improved without going there. And I can see the elongation of the chin. It looks more feminine, more pointy, and the lower lip looks enhanced, which adds to this more alluring, beautiful, more attractive version of herself without changing who she is or westernizing her features.
Great. That's actually a really good point. And in fact, more than 50% of my practice is Asian, and they absolutely, if you treat Asian patients, please don't widen their zygoma. They already have wide zygomas, and they absolutely hate it. What's really lacking in a lot of Asians is actually the medial cheek area. That's particularly a big problem with the Asian population. So yeah, I did use more fillers. In fact, what I did with her is she did. This is the after pictures after 2 rounds of. The first round was 5 syringes of Bellafill, and then the second round was another 5 syringes of Bellafill. So a total of 10 syringes of Bellafill. Keep in mind, each syringe of Bellafill is only 0.8, so it's not your radius is 1.5 or the volume was 1. It's 0.8, so it's actually less than a cc. And so starting top and bottom, yeah, her forehead was very concave, and this is a big thing with Asian culture too, is they have to have a good forehead. They're so obsessed with their foreheads. If you go to Korea, as often as women get their lips done here, they get their forehead. Fat transfers to the forehead, fillers to the forehead. It's a sign of good fortune and good health and good luck to have a nice, prosperous forehead, which reflects on a prosperous lifestyle. So I did fill in the forehead. The medial cheek, a little bit in the tear trough. I'm a little bit careful about PMMA in the tear trough, and I go submuscular, 0.2 at a time, so not a whole lot of volume, just to be on the safe side. I did do some hyaluronic acid HAs in her lips, and she's coming back more for more Bellafill, and the next will be some threads.
Great results.
Next is Dr. Buford. This is one of Dr. Buford's before and after pictures.
So this is a 35-year-old patient that came into me, and this is going to illustrate, you guys have all these elaborate, complicated ways that you're treating these things. I didn't do an awful lot to her, but I do think it created a nice rejuvenated appearance. So I guess kind of starting from the end, talk about what you would do, thoughts on the results. I mean, what would you do?
Well, from what I see here on this patient here, she has some sun damage, photo damage, looks like a little bit of melasma on the side of her cheek there. That's something I would address first and foremost as far as the quality and texture of her skin. Once again, I would approach that with different light-based energies. If somebody has melasma, I would not go to BBL, broadband light, or IPL, because that tends to make melasma worse actually. I would do different combination light therapy. It looks like there was some submental fat loss there, so Kybella or PCDC for that for contouring. Her jawline is definitely much more enhanced and defined. That to me, when I tend to do that, I will go ahead and do either Bellafill or Radius along the jawline. Now some people will also use Sculpture, which is equally as good. I also see that you gave her definition and contour in the cheekbones and in the aperture as far as the apex. Her nose tip looks more lifted, if you take a look at it, as well as the distance between the top of the lip and the tip of the nose, and her philtrum looks much more defined.
Top down, I agree, the nose looks lifted. I think her whole profile is just dramatically improved. Her lip, if you look at the true vertical line, everything aligns. Her chin aligns with the lip and her nose, and it's just perfect. I think in terms of volume enhancement, there's probably very little that was done. Minuscule amounts, but there's probably some volume enhancement because her tear trough is alleviated. The jawline looks amazing. I think a couple of ways you can achieve that with this case is either threads, barb threads, or even like a HIFU or like a Ulthera type lifting energy-based device, and or possibly adding the fillers to the jawline. But I think it can be achieved with mesotherapy, Kybella, and an energy-based device, and of course some skin improvement in terms of any laser therapy.
Alan?
Beautiful hair, eyebrows, and eyelashes. So you can choose whether you want to enhance or just protect those areas with non-invasive therapies.
Beautiful. I think you did an amazing job. She looks like 10 years younger to me. How old is she?
She's like, I think late 30s.
Late 30s. So I was going to
36,
say,
37, something like that.
somebody like her, like I saw her, like she actually will respond to everything that you had said. Me being the Sculptra guy, I will do Sculptra, and I think I'll be able to get similar results. Not as sharp probably of the jawbone and the chin. Probably after I do a round Sculptra, I may switch to Radius or a Hydro G Prime product to get that beautiful contour that you achieved on the jawline and the chin. I love what you did with the brow. I don't know if that was done with neurotoxin, but overall she looks like a younger version of herself, even though she is actually young, right? So this is more like an enhancement prevention type of result.
So I agree, amazing result. I think in the left side, in the before picture, even though she's young, I think she looks a little frumpy. I think what you've done is kind of align everything. If you look at the before, there looks like there's a piece missing from the front of her chin, a piece missing in the pre-gel sulcus, and a piece missing at the angle of the mandible. So you've kind of added to that, and now the eye catches that straight line, and the face looks less round and heavy. I think you've done something with neuromodulators to kind of reposition the brows. The skin looks better. I'm still trying to figure out if you really did anything to the neck, or that's just the result of doing the jawline.
So what we did was basically started with the fabric. Okay, put her on a medical skincare regimen, series of chemical peels. We use a lot of microneedling, PRP in our practice as well too. A lot of biologics. That's why you're seeing the improvement in the skin. For the upper third, what you're seeing is the effects of the neuromodulator, as you pointed out with the brow. Try to shape that. Mid face, I try to recreate a V-shaped look, and so I use a lot of fillers for the chin point, lips, also cheeks, so you can create that V up on a woman. I think it's beautiful. So what I did is voluma in the cheeks, Vobella in the lips, and I actually didn't do anything in the chin here. For the neck and jawline, I use the effects of Kybella, which Kybella not only dissolves fat, but it also creates inflammation. And so as we know from inflammation, what happens with that? We get skin tightening. So what I was trying to do essentially is not only get rid of a little bit of fat, so fat dissolution, but also too, I come up along the jawline, I inject the jowls, and I try to create basically a little bit of a lift. So that's what I did for her. Very happy patient, and again, I think I think it really kind of illustrates how you don't have to get very complicated, and you certainly don't have to, we've got surgeons sitting down here. You don't always have to go the surgical route, and you can get a result for a patient they're very pleased with, and that's durable as well.
How many sessions of Kybella did you do to get this result?
I did two vials apiece.
Okay, on one session, or she came one sitting, or she came?
No. Two sessions,
okay.
2 vials in each session.
Okay, beautiful.
Yeah.
And when you do the Kybella, are you using it as a mesotherapy technique into the face as far as for skin tightening, you're diluting it down, or using it?
No, I'm just using it full
Full
concentration.
concentration, but
Yeah,
just
full
lower
concentration.
dosing as far as the injection sites?
Right, exactly. Yeah, usually I'm using about a 0.1. I mean, a lot of times if you're using it for fat dissolution, you're using about a 0.2. So I go a little bit less, and I really spread it diffusely, so I'm creating more of I'm kind of really shrink wrapping everything. So I'm trying to address the submental fat, but also trying to address the skin laxity around that and create a more sculpted jawline that you see.
And would you continue to do that as a meso technique for maintenance, or would you at that point interject the microtoxin for the face and the?
I think a little bit of both.
A little bit of both.
I think a little bit of both. I mean, there's so many. The nice thing about combination therapies is there's so many ways to get from point A to point B.
Right.
I mean, anybody that gets up and says there's only one way to get there, they're very myopic. Okay, because nowadays you can use energy-based devices, biostimulators, fillers, neuromodulators, skincare, what have you, and create. I mean, you're hearing it from the panel here that there's a lot of different variety of ways of doing it. So, first key thing is understand what's in your toolbox, what works best in your hands, and then you can create these great results that are obviously all these results are non-surgical.
And And that's something that I actually want to emphasize that Dr. Beaver just brought up, is that you have to see what's in your toolbox. Everybody has different clinical expertise and skills, and this is the reason too, through Empire Medical Training, when people come and take these training courses and programs, people get the wisdom, the pearls, the different experience from every single instructor who has different experience and expertise. And I think that's something that we all learn from each other. That's the reason we go to conferences, go to CMEs, we all have these panel discussions, we all compare notes with each other because we can all learn from each other. And I think that's something that is very valuable for any practitioner, especially in the world of aesthetics, from a safety standpoint, from a cosmetic end result standpoint, as well as just for people to be able to enhance and give natural results, as opposed to just doing things because not one size fits all, as we know in the world of aesthetics.
Yeah, I mean, I would add to that you know, learning from your peers is invaluable. You know, and if you think you're so talented, you don't have to learn anything anymore. It's about that time to hang up the shingle.
Absolutely.
It really is.
Absolutely, that's so true.
Okay, so similar thing. Actually, the after, they misplaced it. After's on the left. Before is on the right side. So what would you guys? I'll start with Ramton. What would you or Dr.
Yeah, from the redness on the after, I would say she definitely got some sort of laser surfacing or some sort of tightening device to her face and neck. Lips look enhanced. The distance from the nose to the upper lip looks shorter, so that looks more youthful and aesthetic. Upper third of the face has been lifted, I would guess neuromodulators, and maybe even some along the jawline. Nice job.
Sheena?
Yeah, I think the skin quality looks amazing, so kudos for doing that for her. Again, she looks relatively young, but start looking a little bit tired, a little frumpy. But I can see, again, you do a great job in giving that really beautiful triangle of U shape. The jawline, I love the way you always do jawline, and the chin, so she looks so much refreshed. Definitely a few years younger, even though she's young, but definitely looks like a younger version of herself.
Mm-hmm.
I'm sure you're recommending a non-invasive regimen to her for her hair because it looks beautiful. It's gorgeous and shiny and full and thick. So maybe she's using low-level laser therapy, or
We actually use Nutrafol for most of our patients.
I was going to say
so-
nutraceuticals. So
Yeah.
Nutrafol,
Which I'm on as well too. I mean, no plug for it, but it's, you know, it does work. You know.
Me
Great
too, I
practice.
take it just for prevention, you never know.
And I
Oh, it
take
totally does.
I take the Nutrafol for women. I think we all.
Oh, it's
do
great.
too.
I mean,
It works
you know,
great for everyone.
I mean,
yeah.
why wait until your hair is not good quality? I mean, I think you.
No, you have to be proactive, and so that's super smart.
Right.
Such great nutraceuticals. Nutrafol is definitely an excellent choice.
Right.
Excellent choice. Low-level laser therapy, something she could do at home, in the comfort of her own home, to really stimulate good functioning from the follicles. And if she did need PRP, that's something we would do once a year
Right.
in the office.
Yeah, I think very minimalistic approach to this one, just to get her to the after. You know, skincare regimen, maybe some microneedling with some PRP, some periocular, the rhytids there. The lip definitely looks enhanced, which helps her profile. Again, looking at the true vertical line and the profile enhancement, and some chemical peels possibly. But I think very little, if any, or maybe not even any filler was used in this case.
Right.
Except for the lips.
From looking at this, what I see, what catches my eye is the way that you actually have contoured the nose, and she has much more definition on the nasal bridge, and that's the result from the skin tightening or the result of enhancement with the fillers. I think that's actually a very good result. She definitely looks much more angled, contoured, and she has definition in her face, which she didn't have before. So that approach to me would be a combination of chemical peels, laser light therapies, as well as radiofrequency microneedling, because I think that's a great energy for tightening. And then the filler For me, I tend to do a combination of fillers. I actually layer my fillers depending on if I'm trying to go ahead and do the contouring for the jaw and the cheekbone. I will go ahead and layer the radius and then balloon on top of it, or combine it with sculpture throughout, because the sculpture also, what's nice about it is also enhances the quality of the skin that I've seen.
Right. You know, you're talking about biostimulators. A lot of times what we'll do, depending upon our patient's age and so forth, and what they want to accomplish, it's very, very common for us to actually combine things like PRP actually with her fillers. So here, the redness, unfortunately, she actually didn't get a chemical, or she didn't get a laser, she got chemical peels. She went out and sunburned, unfortunately. So sorry guys, this is not from any of that stuff. I actually did nothing to the nasal bridge. Improvement in skin quality was a series of basically a good skincare regimen, chemical peels, as well as microneedling with PRP. And also too, I'm a big fan of restoring volume to the mid-face, and then going back down. TJ, I think you pointed this out exactly. Her lips obviously have been restored. Trying to create that V-shaped look. And again, I look at starting at the chin point. I look at the width of the jawline as well too. You're seeing an oblique view, so you can't tell. But she did not need any narrowing. If I do, and this is very, very common, I'll use a neuromodulator to actually try to kind of narrow that jawline in and really restore that heart shape or V shape look. So that's what we did here. So I mean, pretty straightforward, pretty simple combination approach.
How many syringes of filler do you use to restore the big face at the?
Someone this age, usually about 2 or 3 of Illuma.
Beautiful.
Yeah, I mean, I don't need a lot.
Yeah.
So the next patient is a patient of mine, whereby it is an Asian patient that you will see. And as you can see, with Asians, as we discussed, a lot of them are concerned about the nasal shape of the flatness and the flat bridge at the tip of their nose. So this is a before, this is her after. So let's start with Dr. Kathir.
Let's see the before again. Okay, the after. So the dorsum and the tip look projected. So from the base view, she's more triangular and a little bit more aesthetic, and she has more of a bridge. So it kind of takes care of that flattened look from the front and the side. So it's nice job, nice aesthetic result.
What would you do?
What would I do?
Surgically versus non-surgically.
Well, since this is a non-surgical talk, I would do non-surgical on her. I would essentially do what you did. I would build her bridge, her nasal tip, and her nasolabial angle with HAs.
With HAs. You would not use radius or Bellafill or any of those, right?
Categorically, no.
Yeah. Okay. Dr. Buford?
Same thing. I would use HAs. The biggest fear that I have is some type of a embolic event or occlusion. So I'm going to want something that I can easily break down if and when that becomes a reality. And I would do the same thing. But I mean, nice job. I mean, I think the non-surgical rhinoplasty is becoming more popular. I urge anyone performing it though, understand the anatomy before doing it. It is so important to know where to inject, and also as well too, which product to inject.
Absolutely. Sheena?
Yes, I don't do tons of non-surgical rhinoplasty. Do I do it? Yes. I have to be honest, this is an area that really keeps me up at night whenever I do it. I tell my patients, I don't care if it's 3 in the morning, you have discomfort, please call the service and I will meet you here. That's something that sometimes you don't want to tell your patient. And I do it, especially when somebody already have a rhinoplasty, because as I take a cadaver course every 2 years and I always get humbled by what I see. I take precautions when I do it, avoid high velocity when working on this area, large volumes. Always check your work, count to 6 to 10 seconds to make sure that you're not intravascular. There's a lot of different ways how the facial artery can cross the nose and a lot of variations. So just because never think that's not going to happen to you, be prepared. to act properly when something happened to you. So I tend to decline any patient that already have a rhinoplasty. I will send it to a plastic surgeons that do non-surgical rhinoplasty because I like to sleep well at night. So if you decide to do this, make sure that you know anatomy and you know if there's a complication, how to treat the complication.
I absolutely agree, and that's something I always share with everybody when I'm teaching any classes at the program.
A beautiful result. Congratulations. But obviously what I'm noticing is that she has hypotrichosis of the eyelashes. Her lashes are very short and thin and maybe even sparse. You can barely even see them in the before and after photos. So if she has some lashes there, we could use a little bit of Latisse, Bomatoprost, or a Revitalash type of product. But very often Asian patients come to see me because they have very low density lashes or lashes that are growing very short. So eyelash transplantation is very popular in the Asian population. Eyelashes grow permanently in the lid once transplanted, and eyelash transplantation comes with scissors because she has to continue to trim them probably each month. That's maybe twice a month.
Oh,
So
wow.
and curl, perhaps even perm them, depending on her curl and caliber of the hair in the back of the scalp that we use.
Interesting. That's good to know. Thank you. Dr. Ortiz,
So having such a high number of Asian clients, they always ask for non-surgical rhinoplasty because I'm not a surgeon. And the typical comments I get from them is, I have a pug nose, my tip looks like a doorknob. And basically they want their bridge elevated because typically Asians, we don't have a bridge, so they want to look more westernized. And so you got to be careful. And again, I do take cadaver courses at least yearly just to familiarize with the anatomy. And so you got to be careful. I do turn away if they have prior rhinoplasties. I know that it changes the anatomy. They're not happy about it, but I've done it a few times. But I try to stay away from those high-risk cases. And I usually don't take a nose case before coming to an Empire teaching event the next day, because and I have them send me a picture right afterwards. But using HAs, I like either something with high G prime, Voluma Wrestling Lift has a higher G prime. I used to use a lot of Radius. I don't anymore just because of apparently you can't dissolve it, but you actually can. And just regarding the tip, I use a technique where I learned in Asia. They use a cannula and they go from the tip with a 22 gauge cannula straight down the spine, and they draw retrograde up and lift. And they've done like thousands of these, and on a study it had not one single problem. So that's a very safe technique for lifting the tip and elevating the bridge. So very nice work, whatever you did.
So I actually did not use any HA on this patient. I did not use any filler. This patient was treated completely with PDO threads and Botox for the neuromodulator. The neuromodulator was placed in order to lift the tip along with the PDO threads, depending on which type of threads, because there are certain types of threads that you can use for that. Not every company also makes it. But what it does, it goes in as a hook to anchor and lift up and define the bridge of the nose, and the patient was very happy. Now, what I did share with the patient, because as you can see, the definition of the bridge is nice, but if she needs more projection, at that point then I would bring her back and then I would go ahead and add the fillers to it if she decided that she wanted to do that. And as well as with your approaches, what you just mentioned is how to build the tip, she can get that. But I think from, as you can see, her tip is very well defined there, but it's up to what the patient, how much more she needs.
Beautiful, beautiful work.
Thank you.
Which thread is it? PLLA thread?
PDO.
PCO?
PDO.
PDO.
PDO, which is the polydioxanone, not the PLA. You could use the PLA, but I tend to use the PDO because also, you get as good of a result. The PLA, of course, is much longer longevity. And then, of course, if you were to use the permanent threads, in patients like this, and this is something I say to patients, even with HAs for fillers for the facial contour, I always give my patients the option, especially if they're newbies in the world of aesthetics. If they want something that they don't know if they're going to like or not, then the HAs are all dissolvable. So I'll be like, let's put this in, let's see how you like it, let's contour it and see, and if you don't like it, then we can always dissolve it, take it out, and we can modify it. Once I get accustomed to them, they get accustomed to me, and they want something more longer lasting, more permanent. At that point, I also know what they like, then I will go ahead and add anything that's more long lasting for them as well.
About how many, 6 to 8 on the bridge?
For what, threads?
For your threads, how many single threads? Are they monofilament? Are they multiple
They're
filaments?
hooked.
The hook threads?
hooks.
Hooks.
Yeah, they're a particular type of thread. So believe it or not, that's only,
And just one, or you're deploying many?
you're deploying, actually, the way it goes in, it deploys as a hook, that's how it lifts it up.
I'm
So it
saying
actually
how
will
many?
go ahead and
2 hook threads.
if you
So
did the
how-
monofilament single thread, that's different because you do have to actually position them in a certain direction and technique, as you know, and then you have to put multiple threads and
Mhm.
you have to anchor them properly. That's
Mhm.
correct. You can also use the what I call invasive versus non-invasive threads. So the PDOs are more of the non-invasive. The mint threads that you're talking about are more invasive, and they're a surgical approach, and you actually have to do them under a sterile environment as opposed to an aseptic technique. And that's different because you just basically would hook it up and define and lift it with that, as you know.
How long after? is this
The
taken?
post is immediate.
Immediate, okay.
Mhm.
And how long do you tell them that this result's gonna last?
I tell patients that depending on, as we do with fillers and neuromodulators, depends on their activity, their lifestyle, their body's going to break it down. Because if you think about it with threads, what do? They're neocollagenesis. So even with sculpture, it's neocollagenesis. So depending on the person's lifestyle, so I tell them, the literature will tell you anywhere from 1 to 3 years. The realistic expectations for me to set for them is 12 months, which is 1 year. I tell them at that point we can go ahead and reassess. If they need to continue to add to it, build, or maintain, we add more. If not, and we go into 1.5 years, great. Same thing with fillers.
Do you ever restrict activities after this? I mean, is there
Yes, I
anything-
usually tell them to keep it, stay calm, stay, rested, relaxed for
facials or
48
anything like
hours,
that.
just like I do with Botox and fillers as well, and no facials, oh, absolutely.
Right.
No facials for 2 weeks with any thread procedure, no laser procedures for 4 to 6 weeks. Just because you don't want to disengage the threads, you do not want to break down the threads, or you don't want them to move somewhere else, just like you would not want filler to be displaced.
Do you personally feel like with a thread nose lift, it's less riskier for vascular compromise? Because
Absolutely.
even with an HA, you can get compression causing necrosis, but
Absolutely. With the PDO threads, what's nice about them is that you have minimal to no vascular occlusion. Now, when I say that, I'm talking about the thread itself is not going to cause vascular occlusion. Now, if you don't know proper technique, proper anatomy, you can cause vascular occlusion because how do you get it if it's not the product? You get an occlusion crisis by compression. So if you hit a major artery and vessel and you have a hematoma and swelling and you don't, immediately respond to the situation, from compression you can still get occlusion. So with the nose, you still need to know for any kind of rhinoplasty approach is your anatomy. You need to basically make sure you don't hit any major artery or vessel, but the actual product being the PDO thread is a non-occlusive type of product. So yes, it's much minimal risk compared to HAs.
No, continue.
We have
Yeah, that's-
Dr. Kassir.
Yes, please continue.
So Dr. Kassir's next patient.
So, this is a patient that came, she's young, she's probably in her mid to late 20s, and disliked the appearance of her nose, and you tell me what we did. Dr. Buford.
I'm gonna guess a non-surgical rhinoplasty. So in other words, injecting basically along the dorsum and also to at the root of the nose as well too. I mean, I think this is, you basically, you lifted up the tip, you restored essentially more linear, angular look to the dorsum as well too. I mean, great result. I was also looking at chin points. A lot of times when we treat the nose, we also have to take into account the chin point as well too. But to me, it doesn't look like you did anything with the chin, and I mean, they look really well balanced now. Looks great. Nice result.
If this is a non-surgical rhinoplasty, this is amazing, Dr. Kassir. I could see that you lifted the tip of the nose, yeah, and I took that bump out of the nose. But definitely, I would have said that this was a surgical approach. But it looks beautiful because on the before, the tip of the nose is down, but also the nose looked a little bit volvulus, and it seems to be so much thinner now. It's actually very, very impressive work.
Thank you.
Beautiful, beautiful non-surgical rhinoplasty.
yeah, I mean, I'm not a surgeon, so I would approach this non-surgically and using an HA product and, trying to lift that tip up to help with her profile overall. But one more thing that I'd like to probably like maybe refer her out to address her retrognathia and the recessive maxilla.
To me, I would think that's actually a surgical approach, just because the bridge of her nose is much narrower, much slimmer, much more contoured. Her nasal tip is very bulbous pre, and then after the bulbous is no longer there. I'm very impressed as a non-surgical approach. So, is that surgical or non-surgical?
That's actually non-surgical. She and her mother came in, couldn't make up their minds, and when I see vacillation, I politely excuse myself and say, you need to come back when you're ready. So they left the office, and 10 minutes later, they came back into the office and said, no, we at least want to do the non-surgical. When she saw this result, they signed up and did their surgical 6 months later. So this is a classic case where when patients ask, how are you going to make my nose look smaller by adding to it? And if you look at the picture on the left, the bridge, the bump, lead the nose, the tip is underneath that or behind that, or is not projected, if you will. So now the tip is more projected. That's what's leading the nose. The profile falls back in a nice straight line, which the eye likes to appreciate that. And there's actually some at the base of the nose too, to kind of turn the nose up and keep it up. If you go to the next slide.
Actually, before you go on, can I ask you a question?
Sure.
Do you ever, on this case, do you ever use neuromodulator as well too at the base to kind of decrease the, like a plunging tip?
Never seen that work.
No? You don't think so? Okay.
You don't think the neuromodulator works?
No, I think if you see
Right there?
well, if you see the muscles that, we cut the depressor septi in surgery a lot, and over the years, even a lot of surgeons, including me, have realized that doesn't do much. It has to do with the ligamentous support of the nose, which is a Piconese ligament and everything. But anyway, so no, I don't do Botox for that.
I've seen it work with Botox by injecting the nerves, the typical area.
Yeah.
However, it doesn't last that long.
Correct.
So that's the problem.
Yeah.
It's like at the beginning it's there, and the patient, sometimes they don't notice that everything just dropped again. It doesn't last that long.
That's
So
very true.
that's the only problem that I have with that technique.
They have to come in more often for it if they're going to do that, correct?
So this patient was, when my WhatsApp was going off, and finally I answered, and it's a friend of mine in Dubai, and he says, look what happened, help me. So we'll start with you down the line and tell me what happened here.
That looks like a vascular occlusion.
From?
Nose filler, or basically she could have had filler underneath the eyes.
Okay. Doc, down.
Yeah, this is probably within 72 hours. The violaceous hue, it's starting to erupt in vesicles, so it's not like that far out. I would, if I recognize it this early, of course, try to get reperfusion. And for me, I've had experience where I sent it to hyperbaric chamber and got complete resolution of the issue right away.
Definitely, this is a sign of impending necrosis. One thing that I try to teach that when you inject and you get this purpura, which everybody that's watching this, you need to memorize this color, because no purpura, it's not purpurate, it's this maroon, reddish, reticulated. Once you see this color, you know you're in trouble and you have to act promptly. But the other tip is that if you inject and the purpura is creeping up, the bruise is creeping up, that's also a sign of impending necrosis, because a real bruise gravity will pull it down. So this usually is like where something that was injected below and it's time to move towards the following the track of the artery. So either something was done below. Now, by looking at the necrosis, sometimes we see this when people trying to get rid of the number 11 in the glabella, and also that can create this type of appearance on the nose.
What product was injected, can I ask? Was it an HA or non-HA?
HA.
I mean, I'd flood this with Hylenex or any of the other enzymes. I mean, you really have to use a ton of that product. And it really depends on how far out it is. I mean, if she's 4 or 5 days out, I've actually seen cases of delayed avascular necrosis. So you really kind of have to factor that in. But the first thing really is to try to break up as much product as possible. Supportive care, restore the perfusion. And really kind of keep an eye on the modeling and so forth. I don't really see any vesicles yet. I mean, so it tells me it's a little bit early. But again, trying to break that product up early. That's a key thing. And early diagnosis.
So where was the HA injected?
So can we go to the next slide? Okay,
Oh.
so this is kind of a similar thing on a different person. The HA in the last slide was
send them this paper, and you have to be prepared. Okay, so you have to have your hyaluronidase drawn up, ready when you're testing anyone, not just the nose. You have to have like this kit that I show in here. You have to have it ready for with you. And the bottom line is there's two forms of compression. Intrinsic, you should see immediately. It blanches. There's just no two ways about it. Like when you inject lidocaine into the vessel, it blanches. So if you see that, first you stop injecting, and then I've even gone into other vessels when patients have come to me and injected the facial artery to send the vitreous up there and dissolve it. So that intrinsic you should immediately see, and there shouldn't be any ifs, ands, or buts about that. Extrinsic compression from just injecting too much filler comes later, and then you should be prepared for that. And as the panelist said, you should let your patients know that if A, B, and C happens, come back immediately.
And that's something, actually, a very good point, because in any filler class, something I emphasize to all the students and trainees is I always tell them, you have to be equipped to handle complication or else don't be doing the procedure. And if you don't know your facial anatomy, if you don't know what I call my little facial aesthetic crash cart, and I tell people to pull them together, it needs to include your hyaluronidase, as you had just said. They should have nitro paste on it. They have to have the warm compresses because you need to flood it with the Hylonex or hyaluronidase. You need to actually put the nitro paste. Of course, you should also be able to monitor the patient and flood the area with the nitro paste. Their blood pressure may drop as well. And these are a lot of things that people need to learn, which is part of the basics. Granted, it's something that I deal with daily in the operating room, but it's something that I try to share with everyone else also that's non-surgical outside of the OR, because I think safety comes first.
I'm gonna point out something. I'm gonna disagree with you. Last couple of meetings that I've been in, actually, nitropaste is actually found to be not effective.
Not effective for vascular occlusion?
No, not effective. Zero efficacy. The big thing is really using a lot of Hylonex. I mean, we're talking hundreds of units. Okay, I mean, not just, and most of these vials are 150 units per ml. I mean, we're talking about, if you're going to do the injectables, you need to have at least 4 or 5 of them on hand, and you flood it until you get that perfusion. I mean,
absolutely.
You don't push it around with it. But I want to point that out just because, I mean, there's a lot of old ways of doing it, trying to aspirate and so forth. I mean, aspirating the volume out of there, it's absolute nonsense. It's a needle in a haystack. The first thing you do is you don't try to pull things out. You try to put Hylonex in, or Hylonex or vitreous or whatever, white is what happening. But it's really
that's very correct. That's true. I mean, the nitro is because of the fact that you need the vasodilatation along with the Hylonex. It's not in place
but
of the Hylonex.
It's been shown to be effective.
But I have to say something about that because I actually was a victim of of doing a non-dissolvable filler on my chin. It was the last little bit, 0.2 cc, that there was nowhere to put it, and I told my colleague, just put it right here on my chin. It was radius. I'm working at my residence, like, you know, there's something really wrong with your lip. All I felt is numbness. Oh, it's just the lidocaine. But no, you gotta go to the bathroom, look at your lip. And it was really swollen. That's the only sign. I had to run to get a plane and go to train a plastic surgery group in Tampa. And the bottom of my lip felt like I just drank a tea, and it was burning a little bit, and vesicles were forming. And I went to the bathroom, and I saw that reticulated, maroon, and nothing to do. Later, hours passed, and I went to the bathroom, and my top lip, it looked very purple. I had the photos. There was nothing that the plastic surgeon had but NitroPaste, and that's the only thing that I did. Within 6 hours of doing the NitroPaste, and I have the photos I can share it to you, I have perfusion on my lip and everything reversed. I believe that it depends what type of artery you occluded. If it's a very large, important artery, probably I was going to be completely screwed, pardon me, the language. But I think it was small because everything was...
But you're talking about a non-absorbable filler, or a non-dissolvable filler.
See, that's radius
with all due respect, that's completely different, though. Completely different. If you're working with an HA, I mean, the first thing you do is not nitrogen.
Oh, no, definitely.
It's definitely.
I agree with you. I agree with you.
Oh,
the
yeah.
first thing is first thing you need
but,
to.
I mean, for yours, that I mean, you had nothing else to do to work with. I mean, so I'm glad you had your lip.
Yeah, no, I was afraid I was going to lose it. So I think the idea is that to agree is that we need to have our protocol in place, and everybody. So my protocol is NitroPaste to vasodilate. If it's an HA, definitely use HA, and you could do, I think, doses up to 1,000 in one day to remove the HA. I put on aspirin, flushing niacin because it helps you flush, and I had them come into the office and put on the red light to increase microcirculation. So that's my protocol. Do that, but definitely the first thing is this.
Warm moist heat as well too.
Yeah.
Is one thing.
Well, that's why I said it was
For
more proper.
vasodilate. Some people actually will use, interestingly enough, Viagra. I mean, because
Definitely.
Viagra, you know,
Yeah.
So-
Because the whole goal is to get blood flow back to that area
Right.
so that you don't end up getting the necrosis and the sloughing off and losing.
I mean, I think the most important thing is, you know, is making a diagnosis.
Recognition.
I mean, that's the problem.
Recognizing it,
Is
yes.
There's a lot of misdiagnosis, you know, or lack of diagnosis, and so it's really identifying it and then knowing how to effectively treat it.
Absolutely, that I agree.
But yeah, that's critical.
The most important though, and there's a good case of modeling there, the most important point I think everybody should understand and take home, especially for the audience, is that necrosis, whether it's your lip or your skin, and that's not the end of the world. The point I want to make, especially when people try to do the nose or perioral areas, Dr. Chino was talking about doing the peripheral apertures and that's a really, really big danger zone for people who are just starting out. If you get a retinal artery occlusion, none of that stuff helps. There's nothing anyone can do. So just be careful with that. Everything else, okay, you know, necrosis is part of her lip, it'll be fine. You know, it'll slough and it'll be fine. But if you go blind and eye ophthalmologist, no one can do anything about it unless somehow, we have one of those, you know, vein finders. You guys have that in the office? I would just cannulate every major artery around and inject into the arteries and hope that it goes to the central retinal artery and dissolve it. That's the only prayer.
Has that been studied?
It hasn't been studied, but it needs to be studied because you send it to an ophthalmologist, they're not going to be able to do anything.
Absolutely right.
So we're gonna end up with just this photo, just to recap. Remember, memorize this color, have a protocol. Remember, impeded necrosis follows the arteries, so many people sometimes misdiagnose with shingles, impetigo, or cinema, and have your protocol in place ready. One case that I just saw in Colombia, so you can all see that nothing is 100% proof. Impending necrosis of the nesa ala due to PRP injecting ended in cerebral fall that led to a thrombus formation from the PRP in the artery. So not even PRP is safe. And we lead you to that.
You know, just let me just add one more thing. I wanted to just thank our panel for sure. This was really, really interesting. We covered so much good stuff. So thanks to our panel. A lot, if not most of everything that we went over is definitely learnable. Just the things that I want to emphasize. You know, where do you start? How do you learn this information? You know, you start with a good anatomical-based aesthetic training program. Definitely, you know, all the doctors mentioned that they continue yearly with cadaver training. That's very important because, of course, your facial memory is everything with all these facial injectable techniques and so forth. There's different entry-level courses, and something we're doing, of course, next year, which is very exciting, are the different combination-type programs, because all of these cases that we went over, it's not just one technique, it's a combination of things. So I think our students, our providers are really going to learn a lot from the different combination therapy programs that we have.
I just want to thank everyone for today's panel discussion and biomedical training and their annual big event, and we will be seeing this and hosting this live as well as the after event.
Thanks, Doug.
Yeah. So this is stay there. You guys good. Stay there.